So the topic I would be covering is evolving trends in cornea and refractive surgery. There are no financial disclosures. So if you see, the scope of this talk would be under the following headings. So the role of artificial intelligence, smart probes, and lateral flow devices in infectious keratitis. What is the future of transplantations going to look like, and how keratoconus management is going to change. And in refractive surgery, how flapless is the way to go, and lenticular procedures are going to slowly take over from flap-based procedures. So if you see this landmark study from Dr. Venkatesh Prajnasar's group from Arvind, they have done a multimodal deep learning for differentiating bacterial and fungal keratitis using a slit lamp image. So this was taken both from the clinical data model prediction and computer vision model prediction. So that becomes a multi-model model prediction, which is a very unique model of predicting the outcomes of a slit lamp image and predicting whether the ulcer is caused by a fungus or bacteria. So if you see the AI predictability in causing the ulcer, so this is the manual segmentation, this is done by an ophthalmologist, whereas this is the automation segmentation that is done by a computer. But still, despite of the best AIs in place, I want you to concentrate on the graph that is there on the right side. So if you see here, the black curve is the all experts combined, that is Indian experts and non-Indian experts combined together. If you see, that's the black curve. Non-Indian experts in diagnosing infectious keratitis, they are inferior. And when you see only Indian experts in differentiating between bacterial and fungal keratitis, they're far more predictable even than the all experts combined together. So I think still the clinical acumen and your differentiation will definitely have a role despite of the best AIs being in place. So it will only add to the value of the diagnostic power, but it will not take away the diagnostic power of the clinician. And you can see that Indians especially have a superior diagnostic thing when compared to other clinicians in the world. So that blue line is the Indian experts, that is far more predictive value when compared to non-Indian corneal experts. So next, coming to smart probes, this is again a revolutionary way of diagnosing and differentiating between fungal and bacterial keratitis. So probe in the sense is not a physical probe. It is nothing but a fluorescein that thing that will go into the slide in place of a strain. So if you see here, this is the gram stain in above slides, and in the down, these are the probes that are used to differentiate. So in the first slide, you can see BSE1. So by the pattern of the staining of fluorescein, you can identify whether it is gram positive, gram negative, or fungi. Similar to the second smart probe BSE2, it can differentiate again from gram positive, gram negative, and fungi. So if you see BSE1, so if you have a smart probe of BSE1, it will have a high positive correlation with gram positive and fungus, whereas in BSE2, it will have a high predictability for gram negative bacilli. So in future, all you need to do is to take a corneal scraping, put both these probes, and automatically when you see under a fluorescein microscope again is not a fancy equipment, it's a regular microscope with a fluorescein light, and under that if you are able to add this thing, you can easily identify which organism is the cause. Next is the lateral flow devices. This is very similar to our pregnancy devices. This is again from Arvind Eye Hospital, Madurai, from Dr. Venkatesh Prajna. So what here they have done is, once the swab is taken, they put it into the thing, the swab is inoculated into this radiometric analysis. So here you can see it differentiates between species of fungi. So you know that it is a fungal infection. Why it is important to differentiate between Aspergillus and Fusarium? Because Fusarium is easier to treat. With your Natosol, it works well, and if you do a correct treatment, by 2 weeks, you see scarring. Whereas Aspergillus is a very tough organism to handle, for which you need earlier diagnosis, where you may need to add intrastromal voriconazole, additionally voriconazole, and sometimes even systemic voriconazole to take care of Aspergillus. Because Aspergillus keratitis is the common thing that goes into corneal perforations or scleral involvement. So it's more important to identify which fungus is causing this, and in that, I think lateral flow devices will have a role in future. So just to sum up the place of AI and machine learning in cornea and refractive surgery, based on only clinical data, forget about the slit lamp images also, classification between fungal and bacterial keratitis and prediction and need for keratoplasty is also there, based on only on the size of ulcer, history, and all these things taking into consideration. There are now algorithms that can tell you when an ulcer presents to you whether this is going to require a keratoplasty in future or not even an image, just the history, size, morphology. And slit lamp photography, you can definitely see, like in the previous studies, you differentiate between infectious and non-infectious keratitis, you identify corneal dystrophies, you identify surface neoplasms, you can distinguish bacterial and fungal keratitis as shown in the previous studies. Next, coming to AIOS2025, it can detect localized mild corneal edema, it can predict graft detachment also in lamellar surgeries, especially DMEC, where we are doing more commonly now. So AIOS2025 images, if you are able to do a proper AI algorithm, by taking this images itself, you can know whether this DMEC graft is going to stay attached or it's going to require a rebubble. Okay, and also it helps you to identify early Fuchs corneal dystrophy. Next, coming to corneal topography and tomography, now there are a lot of algorithms that are already being used for detection and grading of keratoconus, and also outcomes of intrastromal ring segments, how the refraction is going to change. IVCM is not very practical for us, it's mostly used in institutes, but however, correlating to corneal nerve features, again it helps us to diagnose diabetic neuropathy that causes dry eye and assess its severity, and it also diagnoses fungal keratitis based on the fungal filaments that you see in the IVCM. Coming to refractive surgery, there are a lot of nomograms for optimizing outcomes in refractive surgery and IOL power calculation, and preoperative screening for corneal refractive surgery, identifying of corneas that are prone to post-CRS, ectasia also you can identify better. So these are already things that we are doing now. You have in your Pentacam series, all these things are already being done. So in cornea, few of them are there, few of them you are going to see in the next 5 years. So coming to keratoplasty, I think slowly the lamellar keratoplasty will be replaced by drug therapies. So now what is happening, retina in form of anti-VEGF therapy will be future, we will be having ROCK inhibitors and cultured endothelial cells. And stromal scars also you can regenerate by using stromal regeneration matrix. Keratoconus, early detection and cross-linking, so minimal surgical intervention would be required. So if you are planning to do cornea fellowship, all you need to learn is therapeutic keratoplasty that's going to stay, because infections still are challenging, and a penetrating keratoplasty, putting the 16 sutures is what would be required. And newer keratoprosthesis options are also in place, like alpha core, hybrid models, liquid cornea that are being developed. So if you see, I'll concentrate more on the endothelial disease, which is more clinically relevant. So if you see, what we were doing previously was PK, that was very highly invasive. Now most of us have adopted to DSEC or DMEC. So now the future trend would be tissue engineering therapy in a severe stage and only a drug therapy in an early stage. So how does that work? So if you see, there is an increased cell proliferation and adhesion and decreased cell apoptosis with Rho kinase inhibitors and cell-based therapies. So this is the mechanism of action that works. So therapeutic role would be in Fuchs endothelial corneal dystrophy and post-cataract corneal decompensation. So first successfully it was done in Kinoshita in Japan. So this was the particular molecule that was used in a rabbit model, and you can see here by day 14 how the control still has edema, and in the where the drug was used, you can see the cornea beautifully clearing up, and you can see the pupil also. Again, first human use, again also by Kinoshita group in Kyoto, and here he has done in 8 patients, only central edema, only use of Rho kinase inhibitors, no cultured endothelial cells. So this again, it has a very good role. If the edema is limited to the central part, you will have good outcomes. Next is post-cataract corneal decompensation. So this is with cultured endothelial cells. This is again Kinoshita group and 2 patients that you can see, corneal decompensation that is clearing up after 3 months of therapy. So if you see, previously we were taught that endothelial cells will not regenerate. So if you see this line, white line, the above is the normal endothelial cells that are there in the periphery. So below the inferior part is the new endothelial cells that have regrown after cultured endothelial cells and Rho kinase inhibitors. How do you differentiate? Their cells are larger and they have darker intercellular borders. If you see morphologically, they both are different. They are not the same. So cell-based therapy would be like an injection, as I have told you, and the patient has to sleep in a retinal position facing down so that the cells go and accumulate on the endothelium, and they form this meshwork of endothelium. And in future, it will be corneal decompensations would be a simple injection into the AC and making the patient sleep on the face down. So this is cultured endothelial cells with ROCK inhibitors that I hope. But the problem would be you need robust cell culture labs, not viable for use as of now, but in future we don't know. You can get it as a sterilized human usage package. And one more interesting thing in the cornea stroma is from the Sayan Basu group from LVP Hyderabad. So what they are doing is they are taking the extracellular matrix and putting in the stromal cells into that and creating a limbal stem cell, stromal limbal stem cells, so that there is a stromal regeneration. So whenever you see a corneal scar, they mix it with the glue and put a drop over that scar. And over a period of time, because of the glue, it retains that cultured stromal cells and it penetrates the stroma, and stromal remodulation happens, clearing the corneal scar. So that's the reason I'm telling in future you will not have DALKs or DMEX, only you will be doing PKs for TPK. Coming to refractive, I think femto-based lenticular procedures are already catching up, and 50% of them, and it would be a preferred procedure until unless there is a contraindication. Flapless surface ablations would stay as an entry-level option for refractive surgery. We'll have better ectasia predictability because of the lot of machine learning that is happening now. You'll have more customized ablation profiles for patients, and taking myopia pandemic into consideration, next 2 decades, you will see revolutionary changes both in myopia management and prevention. So, take home message, learn basic courses in AA and ML from now, apart from your ophthalmology, learn coding. These are the 2 things that I would recommend all of you, especially youngsters. It is not away that we are going to depend more and more on these techniques. Both us and radiology, I think it should also be included in curriculum, if you ask me. Thank you for your time and attention.
That was very good presentation, Madhu, about the futuristic view of the cornea practice. Now, before going to the questions, I request Dr. Ashok to go and connect your laptop so that to save the time. Madhu, can you, the incorporation of AI and ML, mostly at present we are using in the diagnostic aspects. See, there's, what I was thinking is any equipment which is AI or compatible, then there will be a cost involved in the AI application itself. So basic equipment which can be an AI compatible. Then if you ask for an AI, so best example is the disk analysis, other things.
Pharma, we have a non-mydriatic camera that gives you an option for having an AI algorithm at an additional price. If you do, it's like an attachment. You want it, you can take it. Otherwise, you can depend on your clinical skill too. So but it is useful in mass screening.
So similarly, the diagnosis of a corneal ulcer. So if something AI option is available online, so we can use
putting the history and uploading the image. So by itself, it will try to give you an appropriate diagnosis. Coming to microbiology, it will be more simple that every ophthalmologist can use. Like the probes that we have showed, or a simple pregnancy test kind, lateral flow devices. So those would be more user friendly.
Like how we are using the Hill RBF formula, which is AI based, so which is now free. So otherwise what Madhu has presented is involves a lot of cost. Then well, that translates to our patient set of population is a future challenge for us. Thank you, Madhu. You had a wonderful